Great pleasure to introduce our next speaker, Dr. Vincent Guilamo-Ramos. He is the Executive Director of the Institute for Policy Solutions and professor at the Johns Hopkins University School of Medicine. He was previously Dean and Bessie Baker Distinguished Professor of the Duke University School of Nursing and Vice Chancellor for Nursing Affairs, where he realigned the school's mission and strategic plan to advance health equity and social justice, and founded the Center for Latino Adolescent and Family Health. Vincent, you'll be speaking with us today. I look forward to hearing your findings. I read your paper. I know it's very important, and it's a great place to get us all talking about data and thinking about how we work across silos. Thanks.
So good morning. Just one quick correction to the introduction. I'm actually not at the School of Medicine. I'm at the School of Nursing. I'm a very proud nurse, and I think nurses are invisible, and so I want to make sure that I make that small correction. So my apologies, Steve, for starting on that, but I just want to be fair to my profession. So it's a delight to be here, and I'm going to talk in part about a paper that not long ago my group authored, which really asked the fundamental question: if the U.S. was on track to ending HIV. And I am going to provide my views in terms of an answer to that question. But before I do that, I just want to acknowledge the conference organizers. It's great to be here. Thank you very much for the invite. I also want to thank all the people that are here. I see many familiar faces, folks that I admire, that I respect, some that I've not met before, that it's great to sort of be here with you. And then just really in awe of the collective wisdom and the commitment to ending HIV that is represented in this room. And so thank you all for being here today. Here are my disclosures. I serve in a lot of federal committees. I won't go through all, but just a couple. I see some members of CHAC that are here, so just want to say hi, and some members of PACHA are also here, want to say hi. I am working on a report for the National Academies that's revisiting the unequal treatment report, which is being updated, which will soon be released, highlighting that very intentionally. And I receive funding from a number of federal agencies, from V Pharmacy, and also from private foundations. So before I start, I'm going to just take a moment to acknowledge, and it would be very unfair of me if this point weren't made extremely carefully and clearly, that we have made collectively as a nation and as a world tremendous progress in terms of advancing our pursuit of ending HIV and AIDS across our planet, including the United States. I don't want anyone to leave after my talk thinking that Vincent said that we're not making it, because I am going to tell a somewhat different story. And I may do, Rick, you mentioned that sometimes people are expecting from Indian Health Service the negative news. I may be the person this time who's carrying that message. But I did that intentionally in this paper with my colleagues because I wanted to kind of stimulate a conversation. But before I do that, just look at what's on the slide. I mean, tremendous advances in terms of testing, prevention, and treatment, tremendous reduction in overall new infections since the peak in 1985. You can see here improvements in life expectancy for people living with HIV, the mobilization in our country and across our planet in terms of what we've done to collectively address HIV. Societal sentiment has changed, and it's been worse. It's gotten better. Some would argue that it's getting worse again, but it has evolved over time. And then I think that for me, as a nurse who still practices and is very much involved in sort of public health nursing, I think many of the lessons that I learned in HIV have profound utility for many of the challenges that we face, whether it be Mpox or COVID, STIs that have been our hidden epidemic that continue to sort of be a huge problem for us, et cetera. There's a lot to celebrate in terms of HIV, and I want to make sure, and I'm being very intentional, that I say that before I proceed to the next slide. Having said that, this paper asked this fundamental question. The QR code is on the screen. You can see it there. If anyone hasn't read the paper, I certainly would encourage you to check it out. But the bottom line in the paper is that it says that with regularity, that there are existing systems in our country that fail, and that these systems fail in a way that they lead to inequitable failures. I was really happy to see that we had a presentation where the word disparity was not used, but inequity was used. And I actually like that word because inequities speak to unjust and unfair negative outcomes that are clustered. And I think that that's the best word. In our paper, we call them inequities. And so I'm going to try to tell a story now. And you may agree or disagree with me, but I'm going to tell a story about how I view kind of where we are. And I'm taking a very sort of high-level approach. There's a lot of nuance that is not going to be in my time because I've got about 16 minutes left, and I have probably too many slides. So I'm going to make sure that I meet, my timekeeper here. So when I look at annual new infections, which I definitely appreciate as only one indicator, and if you look at sort of what's in green versus blue, the arrows, the average annual reduction before EHE was established was roughly 550. And so the first thing that I notice when I look at the data that's public is that after EHE from 2019 to 2021, that average annual reduction looks much greater. It is much greater. And so top line, there's logic and there's evidence that when you focus efforts and you have a national program that is designed to address those jurisdictions and geographies that have the greatest burden of new infections, then that matters. That's sort of smart public health. And so I want to say that EHE, from my point of view, is doing what it is intended to do. But another question is whether or not it's doing it at the rate that we need it to actually sort of operate and perform. And you can see here that if we are going to reach the 2030 goal, which is the 3,000 new infections in a given year, which, by the way, I could argue that it's unclear to me why it's 3,000, but that's the goal. And so somebody else who's smarter than I can maybe articulate that. But I think if we're going to reach that, then the average reduction that's needed would need to be more than 3,000 cases. And for each year that we don't meet the mark, that number gets larger. And I think that's an important point because in no year that I see are we demonstrating that we can reduce new infections by that amount. Another important point. If you look here, viral suppression. And so in general, we've got this viral suppression goal, which is part of our EHE target of 95% of individuals living with HIV to have sustained viral suppression by 2030. You can see that there is variability. The purple line is the overall line, and actually 66% of the US population that is diagnosed has achieved at their last viral load test viral suppression. So there's a lot of caveats there, diagnosed and last viral load test. I'm using language of sustained viral suppression, which is different. I'll come back to that point a little bit later. But there's variability. You can see the line, 72% white, 64% Latino, 62% Black, 56% injection drug users, et cetera. These are just exemplars. I could provide other groups, certainly the groups that I work with the closest as a nurse practitioner, young people, their viral suppression rates don't look like any of these. They're much lower and they vary within a given year. And so very, very important. There are sort of 8 things that I could think of. You know, when Steve and Chris were asking me to consider, speaking today, I got really nervous and said, what in the world could I say that isn't in the paper that might be interesting? And so I sort of dwindled it down to these 8 points. I think I see these as opportunities for science and for research. I also see them as opportunities for our programmatic efforts. And so I'm going to use the remaining time to kind of develop these a little bit. But you can see here a focus on HIV prevention and treatment inequities and ensuring that our focus is driven by impact. That impact is sort of what we should be seeking in our work. Our policies and laws, do they reflect scientific advances? Or are we seeing in the country an erosion of the use of science to inform policy and practice? Let's do away with the focus on making communities trust us and the sort of, this sort of pursuit of what's typically called medical mistrust, where people are trying to get the communities that we're serving to trust us as healthcare providers. What about developing trustworthiness in the institutions, in the professions, in the policies that we put out? A different angle to the same issue. How do we really address and effectively eliminate harmful social determinants of health? Can we move away from screening and static models that simply allow us to sort of check in an EMR that somebody has housing instability and make a referral? But does that really address the harmful social determinant? I would say no. How do we move from healthcare delivery, which prioritizes fee-for-sick care, to a model of health in our country where investments are going towards supporting the health of populations? How do we diversify our scientific and clinical and community workforce? We have tons of evidence primarily from medicine, but from health professions more broadly, that shows that it really matters who those providers are in terms of the kinds of care and the quality of care. How do we think about ensuring that we have political will and a commitment to ending HIV? I'm gonna pick on Mario for a second. Mario, you mentioned that the pace by which monies are able to sort of get to the street was really pronounced during COVID. Boy, that was amazing. There were all sorts of things as a nurse practitioner that I could do in New York City during COVID that, thank goodness, the governor removed regulatory barriers for New York. But prior to the removal of those regulatory barriers, I could not do those things. But when it was needed, when it mattered, when we were asked as health professionals to show up and actually care for people, those barriers went away and good things happened, And so how do we do that and get serious as a country to ending HIV and other epidemics? And then the financial investment, I realize that there is positive news, and I too am really happy about the federal investments in EHE, but I am deeply concerned, I know some of my public health colleagues in the room will agree with this, at how much money we spend on really sick care in our country and how little we spend on prevention, health promotion, and when people do get sick, restoring their care. And so those are my points, and that's what I'm gonna try to do really quickly, and I'm gonna go through these in a bit of a whirl. I got 9 minutes, a little more than 9 minutes to do this. So the first slide here, you can see that in general, a lot of the sort of discourse has been that we have been making progress on EHE. And I don't want to suggest that we haven't, because we have. And it's very difficult to sort of frame this, because sometimes people have stopped me and said, Vincent, do you realize that your comments could actually have a negative impact on what you care about and what we all care about so deeply? Because somebody might misunderstand that what I'm saying is that this money has been poorly used. I am not saying that. But it also occurs to me that when you look at the data that's publicly available, that there are different relational forms. In some cases, there's been inequitable progress. If you look at the Latino numbers, a reduction in new infections by 3%. There's been stagnation where the numbers haven't really changed for quite a long time. Look at the numbers here around injection drug use. And then also there's been a worsening, and this has been really neglected in terms of a lot of the public discourse. And if you look at young Latino and African American MSM 25 to 34, you can see that those numbers have been increasing significantly in terms of new infections. I'm not representing all groups here, so please do not misinterpret that these are the only groups. I could talk about people with severe and persistent mental illness or people with trans experience, et cetera. I'm simply illustrating that saying that we're improving is not fully capturing the nuance of the data. We need to pay attention to that. I think our policies and laws reflecting scientific advances. Again, this will not be a surprise to folks in the room. We've got many states and jurisdictions where we have HIV criminalization laws, a complete disregard of the science in terms of U equals U. Something that the Human Rights Campaign put out that I was very interested in is that in 2023, there are over 520 anti-LGBTQ bills that have been introduced in state legislatures, a record. You can see here over 220 bills specifically targeting transgender and non-binary people, and a record of 70 anti-LGBTQ laws that have been enacted so far this year. So again, disconnect, complete disconnect. Restoring and building trustworthiness in our healthcare workforce, but also in our institutions. It's not just the actual providers. If you look here, recent MMWR, I was struck by this. It was released by CDC and really spoke to forms of discrimination among Latino individuals who are living with HIV. And you can see here on the slide that attributing HIV discrimination to their race or ethnicity, to their sexual orientation, et cetera. This has been sort of a pronounced finding that I don't think is only true of Latino individuals, but in fact, we've got a problem, despite all of our advances, that many communities simply don't trust us. They don't see us as having their best interests at heart. We also know that a quarter of Americans during COVID actually said that they did not trust the information from the CDC. And I wouldn't just pick on CDC, I actually deeply respect the CDC, but that was true in New York with local departments of health, with state departments of health, with federal guidance that was received. You can see that there have been countless stories. I just picked one from Politico that says CDC wants our trust back. And so again, we've got to think about moving this towards building the science of trustworthiness. Social determinants of health, there's been an evolution. There's a great paper here in the Milbank Quarterly that my group published. Check it out, it's open access. It'll do a much better job, but it points holes in much of the way that we've been addressing social determinants in our country. And it asks us to consider, how can we move to much more dynamic models? How can we think about social processes like systemic and structural racism? How can we think about multi-level interventions that are applied and that really can address the harmful SDOH? How do we think about sort of co-occurring synergistic inequities, life course perspectives? How do we move away from language like vulnerable and start talking about exposure and susceptibility? And then how do we think about resilience, not as something that is an individual level factor, but that is actually a multi-level factor in our institutions and in our policies. I can't say more about this, but what I can do is guide you to the paper, and it does a really neat job at sort of critiquing the current knowledge on SDOH. NIH has this really terrific special issue coming out. David Murray, Dr. David Murray is one of the editors, along with Melody Goodman from NYU. I believe there's one other editor. Forgive me, I don't remember his or her name. But this special issue really asked about methods and analytic strategies for designing studies that could effectively address racism and structural determinants of health. I think there's some cool papers in there. There's at least one, if I can say this humbly, that's my group's paper that uses our RCT in the South Bronx during COVID through the Radix Up initiative, where we were trying to do some pretty novel things to help people stay alive, particularly at a time when Mott Haven, the community that I'm from, where we implemented this study, had the greatest number of cases, hospitalizations, and deaths. So check this special issue out. There's a QR code to our paper. It's also open access. Here's the point about really thinking through moving from healthcare delivery and fee-for-sick care to a system that values and promotes health. Deloitte, they've been doing some amazing work. If there are folks in the room who don't know Dr. Jay Bott, you should get to know him. He runs the Health Equity Institute at Deloitte, and his group of actuaries has been modeling sort of inequitable care. How much is it costing us? And then also modeling a number of things. One of their figures you see on the left. We spend, at this time, 4.1, it's 4.5 trillion now in healthcare, but look at the dots. Treating sickness, that's the biggest blue dot. Imagine if that blue dot could actually be focused on promoting health. Boy, what would that do in terms of our country? If you look on the right, some of the areas in terms of investments, what strikes me is when I look at existing data, NIH and their expenditures on primary care, 0.2%. Look at the workforce and where we're actually working, primary care, small percent. Many providers going into specialty care. When we look at the amount of money in terms of expenditures that goes into primary care, 7%. A lot of that money going into specialty care, as evidenced by what you see on the other side. The scientific workforce, not new, and I won't spend a lot of time on this slide, but I'll simply say that we've got a problem with ensuring that the future generation of scientists is diverse and inclusive. And the age of first R01 has been increasing. We know that. And then also look at those lines on the bottom in terms of who is, in fact, successful. Now, NIH has done tremendous work in trying to address this, but this is the most recent data that I could find. We have a long way to go. We've got problems in the clinical workforce. We're aging. When I started at Bellevue in 1991, I was in my 20s. I'm in my 50s now, and we're all aging. And so those of us that have been around for a while do envision a time when we won't be doing this work, and we need to attract new people into HIV and syndemic care. That hasn't been happening in the way that it should. And we've got insufficient number of trainees pursuing careers in HIV, and there's been a tremendous strain on the workforce and many people leaving or considering alternative ways of practicing. We've got this really tough Supreme Court decision, the UNC Harvard case, that suggests that race should not be considered in terms of formal admissions into universities. Well, I see a huge problem with that in terms of health professions, because we know that the data, this is just one study, that it shows that if you are an African-American individual and your physician or healthcare provider is African-American, you get better preventative screening, better treatment, better outcomes, period. Now, do I think that the answer to all of this is that every single person has to have their provider matched? No. But what I think is that there's an opportunity to A, increase the diversity of our workforce, and B, to try to understand, well, what are they doing that is resulting in better outcomes? And can that be taught? And can health professions actually share that in training a diverse workforce? We've got many regulatory barriers and many people that are left out, and we've got to broaden what it is that we ask them to do. Right now, the traditional sort of HIV workforce is ID physicians, PAs, nurse practitioners, et cetera. There are many more actors that are needed, and I'm going to argue that we need to envision our workforce in new ways, and we need to invite folks in who have historically not been seen as being essential to ending the epidemic. And that includes people with lived experiences, but it also includes folks who address addiction and mental health and housing and all the things that we need to actually end this epidemic. We've got to understand how this team works and how we can efficiently mobilize the team in ways that help us to advance. You can see here that our sentiment is that increasingly people in our country don't see HIV as being a problem. We need to think about that. There's variability here, but more and more the groups that are the least impacted see this as sort of a rear view perspective, and we need to change that. Here's my final point on prevention and financial investment. So 4.5 trillion, the full scale is that little box on the right. I couldn't get it to fit nicely on the main slide. But what I wanted to point out is that you can see the 92 billion that is focused on public health activities is a drop relative to what the expenditures are in health that are primarily going towards caring for people who are ill. Very important, but what about more investments in preventing people from getting ill? Right now, the majority of adult individuals in our country has one or more chronic conditions. If I showed you the modeling data of what we look like by 2040, we have many more people that will have a chronic condition. Is that what we all are about, taking care of people with chronic conditions, or is our job to prevent people from actually developing those chronic conditions? And it's not just aging, because we see them in adolescents and young adults. I'm going to very quickly just wrap up. I'm over by a minute, guys. And so I'm just going to say that I looked at the NIH goals for the future and what they were hoping in their new strategic plan. There's a lot of overlap in the 4 goals with things that I've shared today, but there's some points that I want to make that I see as being opportunities. So you can see the overlap with goal number 1. I won't repeat it, but what I see as being an opportunity for science and for programmatic efforts is a much more firm commitment to addressing inequities. The science of how do we address inequities? How do we shift more towards health and less towards specialty? And I would say that in regard to also NIH expenditures, I did not show you the slide today of how NIH allocates its funds, but I've been working on a paper that is looking at this, and I've been zooming in on a couple of institutes like NIMHG, NINR, that actually have been making significant contributions to health equity work, but many that are doing much less and have much larger budgets. Interesting set of data. Also, really getting serious for goal number 2 about the social determinants of health. You can see the overlap. I won't repeat it, but I think we can do a lot to advance the work on the science of social determinants of health. Addressing in goal number 3, societal sentiment, issues of trustworthiness versus mistrust, our policies and laws, and greater emphasis on funding prevention versus sick care. And our final point is really broadening the definition of our workforce, addressing issues of diversity and inclusion in the scientific, clinical, and community workforce, looking at structural competency versus culturally appropriate care, but really that's the term that I've been using more in my teaching. Workforce congruence, and then policies and laws related to the workforce, removing regulatory barriers that don't make sense for pharmacists, don't make sense for physician assistants, don't make sense for nurses. Thank you very much, and I'm sorry that I'm 3 minutes over, but I appreciate your attention. Thank you.
I'd like to invite the panel to please return. And while you're coming up, there are mics here for questions. Please come with your questions. I want to start the questions. There's been a lot of discussion of the workforce, and Vincent, thank you very much for bringing that up. It's really important. Several panelists have also mentioned workforce development. One of the questions I would have for the panel: whose responsibility is it to move from, to build the advancement in the workforce development sector? I remember when we started HIV prevention, it was, how you slap a condom on it, and there was a lot of bananas. The issue of the community health worker model now is working with much more advanced concepts. Leave aside the question of building health in communities, but, there's this issue of burnout and restructuring the workforce. Where does that sit in the community in our partnerships here, and how do we pursue that agenda? Go ahead, Pam.
I can start with a little bit from the HRSA perspective with this. So I mentioned our AIDS education and training centers, which does train a number of people in the HIV workforce. And one thing that I particularly want to mention is that 75% of AATC trainees are non-clinical providers. So this includes community health workers, this includes social workers, people working in faith-based organizations. And so I think that when people think about the AIDS education training centers and our long history with the AATCs, they think about clinical providers first. They think it's to train doctors, it's to train nurses. But the AATCs really do go beyond, and so I think work really nicely, Vincent, with what you were saying of trying to build up the community-based workforce. And the AATC program is undergoing a recompete right now, so there will be some new advancements coming, and really being able to build up that community-based workforce is a very big commitment from HRSA through the AATCs, but also just in really trying to demonstrate the value of peer navigators, patient navigators, community health workers. So in looking at the work of our EHE jurisdictions, what we've seen over and over again has been the great successes of projects associated with community health workers. And so we're diving into that a little bit further, but really has been a very successful model. Just one particular instance, one jurisdiction, maybe in like 2021, or while COVID was still impacting in-person care delivery, one jurisdiction was using community health workers. They couldn't come into appointments with their clients, which they normally would have before COVID. So they would call the community health worker while in the appointment so that they could still continue to support the clients. And so, the AATCs definitely have one part to play in this that I wanted to mention. So thank you for that question.
I can just add from CDC. Is this working? Our funding announcement has a paragraph in there about workforce development. It's an expectation that the health department will use their resources to put together collaboratives to strengthen the workforce. And then there's a lot of capacity building assistance that we have, and also HRSA has, and others have, that go out to our grantees to help develop their local people as well. And I can say I watch the AATC training programs a lot. The webinars, like the 1-hour webinars, and get CE through them. They're excellent. So they're fun to watch.
I've just got one comment I want to make. I think it's always multi-pronged to answer a question like that, but I go back to the idea of community, from the community, by the community, for the community. That adage that I just love, nothing about us without us, but talking about what does a community need, I can have lots of things to offer a community, but unless I know that community, unless I talk with them, unless they tell me what are those things they need on the ground, and it's really important that we hire people from the community, we pay people from the community, we let people... I just think there's so many times like, oh, we need a PrEP navigator, but the person is not from the community. They don't know what it's like to talk about sex. They don't know what it's like to be gay. They don't know what it's like to identify as two-spirit. So I just think it builds up some barriers. But we just started something called a U=U ambassador program. And I love, Vincent, you talked about the U=U project, and one of the previous speakers, we talked about how do we take research and relate it. And I think there was a question over there, how do we make people understand it in our communities? I think that was a prime example. It brought a message of years and years and years of research down to the community level that we can remember that, we can train people to talk about it, and we're giving power back to the people in the community living with HIV.
Thanks. So on the other side of the spectrum, the research workforce, I think, is a major concern. We have been tracking success rates for early career and early stage investigators, both broadly and among the HIV portfolio for a while now. And it's not looking great. So I'm happy to say that our office has really doubled down on this work. Just this year, we've changed some of our internal policies that we not only are supporting the NIH institutes to fund early investigators, but fund folks with maybe not the best scores, to Dr. Dale's point before, and allow them to grow and bridge into their first applications. We're also funding the out years of those grants, so not just the first, but the entire life of the award. So hopefully by doing this, might be drops in the bucket, but we are trying to increase the HIV research workforce and supplement the great work that the ICs are already doing. To that end, please note, April 24th is our, I think, 3rd annual Early Career Investigator Workshop, where it's a kind of one-day seminar of everything you wanted to know but are afraid to ask about applying for HIV research at the NIH. So please mark that date, April 24th, and the details are on our website. Thanks.
Great, thanks.
Good morning, everyone. Tom Giordano, is it on? Yeah, okay, thank you. Tom Giordano, I'm Baylor College of Medicine from Houston, Texas. I'm also the director of the Texas Developmental Center for AIDS Research. I wanted to shift the focus. Thank you for wonderful presentations and talk, Vincent. I wanted to shift the focus a little bit to the south. Being from Texas, I'm very familiar with what's happening on the ground there. In particular around, obviously, ending the HIV epidemic. When you look at what's happening, there's not as much progress as there is in other areas, but 36% of people, by at least one estimate, with HIV live in states that have not expanded Medicaid. The federal response, if you look at HRSA funding for HIV, Part A and Part B, it's roughly $2,000 per person living with HIV, kind of flatly funded across the jurisdictions in the U.S., the states in the U.S. But if you haven't expanded Medicaid, your $2,000 per person living with HIV is used really for paying for doctor's visits and drugs. Whereas in states that have expanded Medicaid, a lot of those resources can be directed towards wraparound services. I see a lot of nodding heads. You all know this already. And there's a very challenging question here about how do you provide an equitable response to ending the HIV epidemic in states that have chosen, or areas that have chosen, to not take advantage of things that they could do to help end the HIV epidemic? What's the right response? In Texas, we haven't expanded Medicaid. There's basically no state resources that go to HIV. There's really no local resources that go to HIV either. If it's not federally funded, it's not happening in Houston. And so, can you guys please discuss what you can do at your agencies that might help people who live in states like Texas that have chosen to not take advantage of some resources, that is, to expand the efforts to end the HIV epidemic, thinking on the level of policy and trying to nudge the states or jurisdictions to take a more equitable approach, a more proactive approach. Because what's innovative in California is not doable in Texas, to put it bluntly.
Yeah, I can't answer the question, but I can, make
And if I may, I'm sorry. I realize I'm speaking to friends here, and I'm not calling you guys out. I know you want to help, but I'm interested in what things you can do to help.
Yeah, I mean, our funding strategy to health departments is a prevalence-based strategy. So try to go where the people are, and then we, in the funding announcement, we asked the jurisdictions to then direct it to where the people are, and so where the the concentration. So in Texas, it's going to be the big cities and such. And then of course with the EHE funding, which is there's additional funding that goes to for instance, to Texas for the EHE counties where they can put additional resources there, but it doesn't address what you're asking. I understand that. So that's the approach that we take as a prevalence-based funding stream. The other thing I would say to that is we do allow, this doesn't answer your question directly, but we do allow up to 10% of the funding to be used for syndemic approaches to care, because we all recognize that this syndemic HIV, STIs, TB, viral hepatitis, substance use disorder, it goes together. And so we allow funding to be more purposely directed to integrated screening, integrated referrals, these things. So let me see if anybody else has the answer.
I think that the short answer is you vote and you fight voter suppression to get these knuckleheads out of office.
There you go.
But I do think that we need to sort of evolve the federal investment patterns so that if you are a Medicaid expansion state and a large fraction of your core HIV treatments financed by Medicaid, we should be allowed to use Ryan White program funds differently, because we don't have the same complement needs as Texas and 9 other states who have an expanded Medicaid. So I think that's important. And maybe we have sort of a 2-track system, but we also need to make sure that we don't harm the folks in Texas who need the services the most.
Yes.
The inequity is daunting, so we have to be very careful how we sort of approach that.
Yes. So Tom, just another another set of thoughts on that question. So one is I really like both answers, but I'm going to zoom in on what Mario said about voting. And I wrote down a couple of things here. First, there is data that exists. Patrick Sullivan recently showed me some data that was focused on AIDSView, with Medicaid expansion states versus those that didn't. And I think that those data are readily available. I would reach out to him. It's quite profound. And much of what was commented on by Mario during his presentation is in fact supported by evidence. States that didn't expand are having a harder time. I think it's pretty clear. I would say vote. I would say really elevating the circumstances on the ground. Recently, Pacha spent a week in Houston, and boy, was that an eye-opening sort of week in terms of hearing from people in Houston about the nuance of what's happening. Public comments, where too often people are not sort of showing up in places where elected officials and government-appointed folks can hear what's happening. The media and engaging the media. There are folks in the room that I see that are part of the media telling those stories. And then also research and showing how the research that you're doing in your local jurisdiction highlights some of those needs. Those are all tools. They're not an answer, but they're certainly better than some of the missed opportunities that I see, because I know when people show up and make points clear, that folks are listening and they do want to help.
If I may, to that, Vincent, I had the opportunity to talk at the Pacha meeting in Houston, and some of my comments were just a distillation of that talk. But there is a issue that if you speak up in some jurisdictions, you actually put a target on your back. Look what happened in Tennessee, and there's other examples of that. So those of us living in these difficult environments, we have to be very careful about when we actually stand up and wave our flags versus when we try to operate under the radar.
Noted. Thanks.
Hi, everyone. My name's Sam. I'm a third-year psychiatry resident at University of Chicago. And so it's been really exciting to hear the word mental health mentioned a number of times. But I often find that is kind of integrated at the end once people are living with HIV. It is support for mental health care needs. And I'm wondering if you could speak a little bit about moving preventive services into primary mental health care settings. A lot of times, the people that I'm taking care of fall squarely in that 20% that are not well serviced by our current care paradigms. So this is something that I think a lot about, my area of research, and I'm just wondering if you could speak a little bit about kind of what the national focus is on centering people with mental illness as a key population for prevention scale up.
I can say some things. I wish Kristin was right here
I know.
to answer your question. She would be the person for that question. Just one thing that I'll point out is that through the Ryan White program, one of the service categories that we do support is mental health services. And so that is not contingent on someone reaching viral suppression before they can enter mental health care. And we really have woven that throughout a number of our special projects of national significance, really the whole person approach, and some interventions specifically for people with mental health disorders. But again, I wish Kristin was here.
And Sam, just as a response to your question as well, so I don't know if you saw in Health Affairs, there was a fantastic paper that was written by Secretary Becerra, who was arguing exactly what you're saying. And I forget what the term was, colleagues from HHS may know better than I, but I think he used the term reverse integration of really positioning these services in primary care settings. That seemed to be the official position, and so I think the challenge now is how do we actually implement that?
Working in family medicine, I can say that's a lot easier to say than it is to do. So, yeah. But it's a great thing to do once you do it, yeah.
Good morning, everyone. My name is Dr. Ira Thomas, and I am a member. Okay. And I'm representing the justice involved, or the criminal justice area. And I also want to recognize my colleagues from Miami, Florida. Hey, let them know we're here. The question that we have is, we work with folks who are entering the criminal justice area. Specifically, I coordinate reentry services for Miami-Dade Corrections. And we've not heard anything mentioned about, folks who are within the criminal justice arena, unfortunately. And just wanted to know, how do you guys think about that in terms of your strategy? Are you doing some work? And if so, we want to be a part of it. Okay? So I'll stop there and let you answer.
Hope that there's some questions for other panelists at some point. But yes, let's talk. So through our special projects of national significance, we often will focus initiatives on priority populations, and we actually have two initiatives right now that do focus on people who are or have been justice involved. So one of them is our 2IS program, which is more focused on HIV clinical outcomes, and then our other is our Shore Housing Initiative, which is designed to help provide housing and get people into housing. And one of the focus populations there is people who have been justice involved. So let's definitely talk some more. It's a key priority population for us in HRSA and with the Ryan White program, and we're always looking for opportunities to engage in that work.
It's a key population with American Indian communities as well. A lot of our tribes run their own facilities. So we're finding it more common that it's easy for us to go in and talk directly to the folks who run those institutions and talk about hepatitis C testing and treatment and keeping people on their antiretroviral therapy. So it's getting more and more common, but we have a long way to go. I haven't really touched the state systems yet, but even our county jails, lucky enough to know personally a couple of county sheriffs, and they just have been so approachable and like, come on in, we'd love to talk with you. So I think there's barriers in a lot of places, but I think sometimes it's just that approach. I think some of us still forget we have our community members housed in your facility, so and we need to be that safety net as they are reintegrated as well. Thanks for bringing that up.
Just to add one quick local anecdote. So in LA, we have a large but shrinking incarcerated population, and we have over time integrated programs in the jail system. And regrettably, we're often at the whim of whoever is sort of managing the jails over a given 2 or 3 year period. So it takes a lot of sort of maintenance of the relationship to keep some of those programs in place. But often, if you have champions within the jail who are, understand the cycle of seeing folks over and over again, they like, this is enough. We got to do things differently. So transitional case management programs are very effective. Routine screening programs are very effective. We happy to talk more about some of the stuff we've done in LA.
Thanks, and over to the left.
Thank you. My name is Ariana. I'm a researcher. I do mostly qualitative research, especially with LGBTQ, IA+, young adults, especially like Black and Latino populations. And one of the things we hear a lot with them and also with medical providers is the barrier on, like, financial barrier for healthcare access. We're hearing about that a lot, and also with providers in terms of time and billing. And so it seems to me like there's always this, sorry, I'm such super dry mouth. It seems to me there's always this elephant in the room that we don't talk about, which is like universal healthcare. You know, we're talking about reducing these barriers, especially across like administrative burden, but I'm curious from all of your standpoints whether there's conversations within your agencies about how we move towards that like clear simplification of both for the clients and providers in order to reduce these inequities. Thank you.
Yeah, again, I probably won't directly answer your question, but I think one of the things that all of us in HIV are have moved towards is a whole person approach to HIV prevention, so that we're looking at the person and their needs, not just do they need HIV prevention, HIV treatment, but all the other services they might need. They might need assistance. I mean, the easy ones are not easy. The common ones are things like housing issues or food assistance and things like that, mental health, referrals to mental health and stuff. So I think that's one of the things that's kind of embedded into the milieu of the HIV syndemic world, is that people take a whole person approach, not just for the syndemic infectious diseases, but the other essential support services that they need. But that doesn't answer your question about universal health care. I don't have that answer.
Yeah.
Great, thanks.
Good afternoon. My name is Tamasha Davenport, and I'm from New Orleans. And I'm actually HIV program director of our HIV program for our church. So this is a faith-based organization that has been in the fight for 30 years and counting in New Orleans. So basically we've served just about everyone in those 30 years, especially the Black community. But one thing, I don't know if it could be answered, but just a thought. In our experience, just being at a lot of conferences and just working head first in the community, I think there's a disconnect with research and what's going on in real time. So a delayed reaction, like we don't get results until the research comes out, but while we're waiting for research to come out, we are doing the footwork, and research can be 10 years behind things we've already said. So for instance, we have the term syndemic now. But we've been saying as foot soldiers, drugs, housing, this and that has always been a problem.
Yeah.
So by the time research catches up, we're 10 years behind, and this is where you're getting burnout. Because as foot soldiers, we've been saying, and even when we come to the town hall meetings, even when we send the emails, the results or the feedback is still delayed. So we're being advocates for the people we're serving, but they're not being served efficiently because things are way behind. So for instance, that's the issue with PrEP right now. It's way behind, especially serving Black women. So even if we're saying PrEP this, PrEP that, they're saying that's not for us because that's not how you introduced it. So I have to convince, and we're a church, I can come there with God is good all the time, but they're still not taking PrEP. And to interject with that, we don't come with Bibles and all of that. We come serving, meeting them on the level that they are. So I think that's a disconnect. Numbers are great because I participate in research. We participate in research. We're part of research. I'm a Black woman. But that's not the whole story. So and I love the way Mr. Rick said it, if I don't listen to why they're not doing it, then I cannot develop the service or the activity to at least inform them about it, introduce it to them, or try to convince them. And I think the other thing too, as providers and government, is to understand everybody's not going to buy into what we're giving them. And we really have to understand how to deal with that as well. Because this is not the Department of Corrections where everybody's a number. You get what I mean? These are communities and people, human beings we're serving. And like Ms. Jazzmun, I want to say it correctly, we are in a position to serve. And that means we need to do it the way the people need it and not just what numbers are dictating. Because when we fall short of numbers, our funding is threatened. If we don't have numbers, but it takes a lot for us to get a person tested. I have to tell people, you can't come in my van with that gun because they're trying to protect their homeless tent. That's who we're serving. Not only with church services, but when we're in the streets, when we're in the communities, when we're in transitional homes, when we're in the rehab centers, when we're in the universities. It doesn't always look like policy and procedures.
Thanks.
And the other thing, and I'm gonna sit down because I can talk. I'm a preacher's kid, I can talk. When we see the numbers of dollars on the screen, it doesn't always look that way when it comes to us. From Louisiana, you can give them $50 million. By the time it gets to the CBOs, only $10 million is left. So I got to do the same thing I got to do for 10 years straight on the same budget. I can't do that. So my government, when we're discussing with the health departments or whoever you're funding, we need to discuss what's realistic. Yesterday's prices ain't today's prices.
Anyone on the panel?
I just want to say thank you. We hear you. And I'm pretty sure I can speak for everyone when I say we agree. We can absolutely do better. And involving community perspectives, seeking and employing community perspectives all the way from the research plan, from the research question, the design of the methodology is absolutely integral. We have a long way to go. I do want to acknowledge that we have been trying and trying harder, meeting some resistance at times internally, but we at the NIH have been doing something we refer to as listening sessions, where we come and listen. It's been hard in COVID, but we managed to do several of them virtually in all sorts of different places. New Orleans is actually on our list. So I look forward to engaging with you in the future.
So I'm going to take the privilege to say thank you very much to everyone. I want to also acknowledge that we started the panel with the voice of the community and we end with a question from the community and a comment from the community. So I think this is a nice place to stop because there's so many words that need to be said and we're on a schedule. So I have to break us. We're going to I give you 15 minutes. Oh, Gregory. It's 15 minutes and we'll meet back at 11:15. Please talk with your colleagues up here to continue the discussions. Or you guys can go, but.